We at Dr. K.M. Cherian Institute of Medical Sciences have always kept this at the center of our vision. Serving and supporting our community with humanity and equality. This fulfilling journey in the path of healthcare under the guidance of our founders and forerunners began in the year 2021. Since then, every day poses us with newer challenges and our expert team is always ready to give their best. Hundreds of patients experience services from the region's best doctors and leaders in their specialties spread within 30 departments. Proper and precise diagnosis leading to immediate responses to the cause ensures minimal complications and a highly efficient pattern of treatment. With a 300-plus bedded inpatient department, including royal suite rooms, we bring global healthcare standards closer to home. Here, life begins and dreams take flight with a personalized care and seamless attention. Widening our borders to the rest of the world, Dr. K.M. Cherian Institute of Medical Sciences is opening an international hub for quality medical services. Ensuring the best healthcare for you and your loved ones, we have installed state-of-the-art technology supported by well-trained professionals. With you at the apex of our functioning, we continuously improve clinical procedures and service quality. Frequently training our team in all the growing changes in different medical branches, Dr. K.M. Cherian Institute of Medical Sciences works towards efficient early cure for our patients. Making a whole bouquet of services easily accessible by all, we are committed to the betterment of our patients' lives. Provisioning the best quality products in medical cure and remedies, providing nourishment and wellness for the body and the mind, serving love and healing together. We keep your health at the center of our service. We keep your happiness at the center of our hearts. And we keep striving to ignite the flame of hope in quality healthcare services.
Dr. K.M. Cherian Institute of Medical Science, Kallisheri, Chengannur, is a private limited company. Sri P.M. Sebastian, UAE-based industrialist and medical entrepreneur, is the chairman of this hospital. World-renowned cardiothoracic surgeon Dr. K.M. Cherian is one of the directors and also the head of Cardiothoracic and Vascular Department. Mr. Sibin Sebastian is the vice chairman and Mrs. Sheila Philippos is the deputy chairperson. Other than 14 board of members are here in this private limited company. We are developing project that is called ARA, Analysis, Research and Academic. Under this project, we have conducted 2 international conferences. More than thousands of doctors participated in these 2 conferences. Another feather of the wing is ATPP, Accident Treatment Program with public support. We have conducted training program for police officers and exit staff. More than 1,000 police officers and exit staff of Alappuzha district and Pathanamthitta districts participate in this program. And also training for the drivers of ambulance, taxi, auto shop. We are the frontiers for the society for giving better treatment and help.
Dr. K.M. Cherian, Institute of Medical Sciences, a new hope in healthcare. The language of healthcare extends beyond prescriptions and procedures. It is the service of imprinting a patient's mind with a new and renewed hope for life. We at Dr. K.M. Cherian Institute of Medical Sciences have always kept this at the center of our vision. Serving and supporting our community with humanity and equality. This fulfilling journey in the path of healthcare under the guidance of our founders and forerunners began in the year 2021. Since then, every day poses us with newer challenges and our expert team is always ready to give their best. Hundreds of patients experience services from the region's best doctors and leaders in their specialties spread within 30 departments. Proper and precise diagnosis leading to immediate responses to the cause ensures minimal complications and a highly efficient pattern of treatment. With a 300-plus bedded inpatient department, including royal suite rooms, we bring global healthcare standards closer to home. Here, life begins and dreams take flight with a personalized care and seamless attention. Widening our borders to the rest of the world, Dr. K.M. Cherian Institute of Medical Sciences is opening an international hub for quality medical services. Ensuring the best healthcare for you and your loved ones, we have installed state-of-the-art technology supported by well-trained professionals. With you at the apex of our functioning, we continuously improve clinical procedures and service quality. Frequently training our team in all the growing changes in different medical branches, Dr. K.M. Cherian Institute of Medical Sciences works towards efficient early cure for our patients. Making a whole bouquet of services easily accessible by all, we are committed to the betterment of our patients' lives. Provisioning the best quality products in medical cure and remedies, providing nourishment and wellness for the body and the mind, serving love and healing together. We keep your health at the center of our service. We keep your happiness at the center of our hearts. And we keep striving to ignite the flame of hope in quality healthcare services.
Dr. Cherian Institute of Medical Science, Chengannur, is a private limited company. Sri P.M. Sebastian, UAE-based industrials and medical entrepreneur, is the chairman of this hospital. World-renowned cardiothoracic surgeon Dr. K.M. Cherian is one of the directors and also the head of Cardiothoracic and Vascular Department. Mr. Sibin Sebastian is the vice chairman and Mrs. Sheila Philippos is the deputy chairperson. Other than 14 board of members are here in this private limited company. A developing project that is called ARA, analysis, research, and academic. Under this project, we have conducted 2 international conferences. More than thousands of doctors participated in these 2 conferences. Another hero of the wing is ATPP, Accident Treatment Program with public support. We have conducted training program for police officers and exit staff. More than 1,000 police officers and exit staff of Alappuzha district and Pathanamthitta districts participate in this program. And also training for the drivers of ambulance, taxi, auto rickshaw. We are the frontiers for the society for giving better treatment and help.
Dr. K.M. Cherian, Institute of Medical Sciences, a new hope in healthcare. The language of healthcare extends beyond prescriptions and procedures. It is the service of imprinting a patient's mind with a new and renewed hope for life. We at Dr. K.M. Cherian Institute of Medical Sciences have always kept this at the center of our vision. Serving and supporting our community with humanity and equality. This fulfilling journey in the path of healthcare under the guidance of our founders and forerunners began in the year 2021. Since then, every day poses us with newer challenges and our expert team is always ready to give their best. Hundreds of patients experience services from the region's best doctors and leaders in their specialties spread within 30 departments. Proper and precise diagnosis leading to immediate responses to the cause ensures minimal complications and a highly efficient pattern of treatment. With a 300-plus bedded inpatient department, including royal suite rooms, we bring global healthcare standards closer to home. Here, life begins and dreams take flight with a personalized care and seamless attention. Widening our borders to the rest of the world, Dr. K.M. Cherian Institute of Medical Sciences is opening an international hub for quality medical services. Ensuring the best healthcare for you and your loved ones, we have installed state-of-the-art technology supported by well-trained professionals. With you at the apex of our functioning, we continuously improve clinical procedures and service quality. Frequently training our team in all the growing changes in different medical branches, Dr. K.M. Cherian Institute of Medical Sciences works towards efficient early cure for our patients. Making a whole bouquet of services easily accessible by all, we are committed to the betterment of our patients' lives. Provisioning the best quality products in medical cure and remedies, providing nourishment and wellness for the body and the mind, serving love and healing together. We keep your health at the center of our service. We keep your happiness at the center of our hearts. And we keep striving to ignite the flame of hope in quality healthcare services.
Dr. Cherian Institute of Medical Science, Kallisheri, Chengannur, is a private limited company. Sri PM Sebastian, UAE-based industrials and medical entrepreneur, is the chairman of this hospital. World-renowned cardiothoracic surgeon Dr. Cherian is one of the directors and also the head of Cardiothoracic and Vascular Department. Mr. Sibin Sebastian is the vice chairman and Mrs. Sheila Philippos is the deputy chairperson. Other than 14 board of members are here in this private limited company. We are developing project that is called ARA, Analysis, Research and Academic. Under this project, we have conducted 2 international conferences. More than thousands of doctors participated in these 2 conferences. Another hero of the wing is ATPP, Accident Treatment Program with public support. We have conducted training program for police officers and exit staff. More than 1,000 police officers and exit staff of Alappuzha district and Pathanamthitta districts participate in this program. And also training for the drivers of ambulance, taxi, auto shop. We are the frontiers for the society for giving better treatment and help.
Dr. K.M. Cherian, Institute of Medical Sciences, a new hope in healthcare. The language of healthcare extends beyond prescriptions and procedures. It is the service of imprinting a patient's mind with a new and renewed hope for life. We at Dr. K.M. Cherian Institute of Medical Sciences have always kept this at the center of our vision. Serving and supporting our community with humanity and equality.
Cherian Institute of Medical Sciences. This is part of our ongoing effort and vision to establish a comprehensive cancer care service in our institution, and of course to expand the scope of what we can do for our patients with cancer. The topic for today, cardio-oncology, is a relatively new one. Some of us may have heard about it, but anyway, we have Dr. Amit Arbune, who is a pioneer in this subspecialty, to talk to us today and enlighten us. He is the director of Cardio-Oncology program at the University of Kentucky. I believe Dr. Sara will give a more formal introduction to him. Dr. Amit, great to have you here. We are eager to listen to your presentation and to open our eyes to this new concept. Dr. Sara Iso, Director, Oncology Department, Dr. Cherian Institute of Medical Sciences, Dr. Anand Srinivasan, Senior Cardiologist. They are the people behind organizing this. I don't think they need a formal welcome, but I congratulate you and appreciate the effort put into to setting up this evening. I also welcome all the people who have come here to attend this program, especially after a busy clinical schedule. I hope you have a fruitful and interactive evening. And thank you and a warm welcome to all of you. I'll let Dr. Anand tell you more about the evening. Thank you.
Thank you, Dr. Givaris. Dr. Amit Arbune, can you please take the seat on the dais? Dr. Givaris, he's our medical superintendent of Cherian Institute of Medical Sciences. The next thing on the agenda is the introduction of our cardiology department by Dr. Anand Srinivasan. He's just getting here, so I'm going to step to the next step, which is introduction of the oncology department by me. So, as you know, this meeting is organized by the Oncology Department and the Cardiology Department at the Cherian Institute of Medical Sciences. In our hospital, the Department of Cardiology is one of the strongest departments among all the departments. And it's, I think, the cardiology and cardiovascular surgery started even before the hospital was inaugurated, if I heard that correctly. But oncology, on the other hand, is the newest kid on the block. We just started about 6 months ago. We started our department. So we are still going through the growing stages. So the strongest department and the newest department joined hands in hand to introduce this new topic, cardio-oncology. So like most of you are wondering here, what is cardio-oncology? You will hear more from Dr. Arbune. It's, as you may suspect, it's not regarding cancer of the heart. Cancer of the heart is very rare. Cardio-oncology is a field of medicine that deals with cancer patients with heart disease or cancer patients going through treatment with medications that can affect their heart, how to manage them, how to lead them through their cancer treatment and into survivorship and manage them throughout their course of the illness. So a cardio-oncologist and team will work hand in hand with the oncology team to manage the patients with cardiovascular diseases. It's a growing field globally. There are only very few centers with a cardio-oncology department or a cardio-oncology program. And there are only few experts in the world who are as cardio-oncologists. So we are very fortunate to have one of those experts among us today, Dr. Amit Arbune. Dr. Amit Arbune is an assistant professor of medicine and radiology at the University of Kentucky in USA. He received his medical degree from MGM Medical College in India, then completed his Masters of Healthcare Administration from University of Kentucky. After his internal medicine residency, he completed his cardiology fellowship at Case Western University, where he was a chief fellow as well. He then went on to complete an advanced cardiac imaging and cardio-oncology fellowship at Yale University. He is the founding director of the Cardio-Oncology program at the University of Kentucky. Since inception, the program continues to grow and is recognized as the gold-level center of excellence by the International Cardio-Oncology Society. He also leads the cardio-oncology section for the Global Cancer Consortium. Dr. Amit Arbune. So before Dr. Arbune gives his presentation, I want to invite Dr. Anand Srinivasan, our cardiology specialist, to give a brief introduction about the cardiology department. So before that, I'm going to introduce our oncology department. I am a medical oncologist, I'm Dr. Sarah Iso. Our radiation oncologist, Dr. Boss Vincent. Dr. John Thomas is our surgical oncologist. We have Dr. Murali Appukutan, he is on his way. And we have Dr. Ashwin Balbanaban, he's an interventional radiologist. So this is our main team. Then we have our neurosurgeons here, and various other departments work hand in hand in the oncology departments. So Dr. Anand Srinivasan, please introduce the cardiology department. Dr. Anand will be coming in a few minutes.
Well, while they load up the talk, I firstly want to thank all the organizers for having me here, and also want to congratulate them on their vision for thinking about, like, as they are developing the Cancer Institute and thinking about establishing a center of excellence about involving cardio-oncology right from the get-go. And I'll start into my presentation about what is cardio-oncology. All right, let's see. So I'm going to talk about cardio-oncology in terms of past, present, and the future. A little bit about the past as in where we have come here, and what's where we are right now, and what's next. This is not working. All right, you can go to the next one. All right, go back. All right, before I start about cardio-oncology, as in, I want to say about how I came about to be here. We have a platform called Global Cancer Consortium, which is a consortium that started with University of Kentucky, Mayo Clinic in the USA, along with Manipal in India, and Saroj Gupta and Tata Memorial. These came together to form a consortium, and that has been since initially it started as an Indo-American and has been growing to include more universities in the USA with Brown, and also we have included China and in this University of Sao Paulo. And that's the platform where we have been kind of spreading the education in terms of cancer worldwide. But as people started talking about cardio-oncology, we started the cardio-oncology section for the Global Cancer Consortium, and for which we do regular lectures and have started some training programs as well. And part of which collaborations has been started, and we were discussing, and that's why we talked to Cherian Institute, the leaders here with cardiology, oncology, and the hospital leaders, and that's how I'm here. Keep going. That's the kind of the lectures and things that I was talking about. We also have a global training program for cardio-oncology. Next. So that's the objectives for today's talk. And I'll review the background of cardio-oncology, look at some definitions of what is cardio-oncology, and also various types of cardiotoxicities. Then we'll look at a couple cases, and then finally we will look at some management and take-home points. So review of cardio-oncology. As Dr. Sarah alluded to, what is cardio-oncology? Again, relatively new field for a lot of people. It's been growing in the last 10 years in the United States, but all across the world, it's still a relatively newer field. Really, it started talking about when it started back when we started noticing anthracyclines were causing cardiotoxicity. However, there has been more recognition in the past 10 to 20 years about what cardio-oncology is. Basically, it's a cardiologist working with an oncologist, and that's how we kind of had the two groups here together to collaborate, and where we take care of patients. The aim is to treat their cancers and protect their heart, because cardiac oncology medications can affect the heart. And again, heart disease and cancer are two most common illnesses that people die from in India and also worldwide. Again, more and more patients are diagnosed with cancer in India. This is the last statistics I have, about 13 lakh cancer patients every year in India. Again, as cancer treatment continues to improve, more and more of these people are surviving. There are going to be new cardiotoxicities as newer medications are being developed. And again, in the United States, there are going to be like close to 22 million cancer survivors by 2030. So there are more and more people who are surviving cancer, which has become more of a chronic disease than a death sentence that it was. So these patients have been exposed to cardiotoxic chemotherapy and will have to be managed in future. So how the past, kind of relevance, and how are we here? Cardio-oncology truly, like I said, it started back in 60s and 70s when we started recognizing that anthracyclines, the so-called red devil, can affect the heart. So back in 60s and 70s, we knew the anthracyclines, the higher dose anthracyclines can affect the heart. But then in 90s came the trastuzumab, the anti-HER2 therapies for breast cancer. And subsequently in 2020s, that has expanded to a lot of chemotherapies and immunotherapies. We have the VEGF inhibitors, we have the tyrosine kinase inhibitors, the fluoropyrimidines, and all these have been recognized to cause cardiotoxicity. And this is a slide from MD Anderson when they hired their first cardiologist back in 1970s. And right now, and this is little dated, that's from 2020, but now they have about 20 cardiologists and nurse practitioners taking care of these patients. So really a cancer institute which has employed cardiologists and has a department of cardiology, which is collaborating with the oncologist to make sure that the patients are able to tolerate their chemotherapy and protect their heart as they develop cardiotoxicities or prevent developing cardiotoxicities. And one important thing is for us to recognize is why is cardiology and oncology, why does this happen? Why do cancer patients develop heart disease and vice versa? The thing is, they have shared risk factors like high blood pressure, cholesterol, diabetes, smoking, and again, oxidative, some biological mechanisms like oxidative stress, reactive oxygen species. All of these can cause cancer as well as they can cause heart disease. That's why it's important, and a lot of studies have shown, even the big cardiology studies, that cardiology patients over time develop cancer. Vice versa, patients who have cancer develop heart disease. So because of these shared risk factors, that's why it's important that patients who are at high risk of developing heart disease and have cancer should be treated accordingly. Again, what does oncology involve? It's not fancy in any ways. It is about baseline risk assessment, kind of reviewing their patient's baseline risk factors. Sometimes it involves pre-operative or pre-procedure evaluation, like patients before they get bone marrow transplant and they have high risk, they get evaluated by cardiology. Patients before they get CAR T-cell therapy, which is again a newer cell therapy that can affect heart and can cause cardiomyopathy, those patients get evaluated. Again, this I've not written pre-chemotherapy because that's relatively new and a lot of patients don't get that. Even in the US, that's still happening. We see patients before they get chemotherapy, patients who are high risk or have underlying heart disease, that is this chemotherapy okay for these patients? And we optimize their heart to the best state so that they can tolerate that chemotherapy. Again, longitudinal follow-up. This is important because these patients have risk of developing heart disease, like I said. And again, managing their cardiotoxicities is when they have developed heart disease. So this is a slide from the 2022 European guidelines, where it shows the same things about cardiotoxicity, and these are cancer patients who have first time developed cancer, second time developed cancer, and the downward arrows are what cardio-oncology does. That reduces the risk at baseline while they are receiving their cancer treatment. That's when they have the highest risk of cardiotoxicity, and this is longitudinal follow-up. So it's very, very important to pay attention. There's a lot of patients in this group that will be ignored because while they're getting chemotherapy, we will pick up cardiotoxicity, treat them, but these are the patients that they go unnoticed for years and they subsequently develop cardiotoxicity, and this is what we want to prevent from them to develop cardiotoxicity. So let's look at some of the definitions and various cardiotoxicities. So in the past, as I said, about 1960s and 70s, we knew anthracycline affected the LV. It caused heart failure. But it's gone beyond that. It was the cancer therapeutic-related cardiac dysfunction, which was the LV dysfunction, type 1 being the irreversible kind with anthracyclines, type 2 with the other agents. But we have gone way beyond just LV dysfunction. There is myocarditis that happens with newer immunotherapies, and also some tyrosine kinase inhibitors. Pericarditis, which happens with immune checkpoint inhibitors again, and also pericardial effusion, something like osimertinib, one of the targeted therapies for lung cancer. Again, coronary artery disease, we get vasospasms with 5-FU-related chemotherapies. We can have accelerated atherosclerosis. Again, it can happen with patients who have had radiation to their chest or in patients who are receiving immune checkpoint inhibitors. Again, what we know about immune checkpoints, it's tip of the iceberg, that they can develop myocarditis. However, these patients develop accelerated atherosclerosis, and we have seen that on coronary CTs, that these patients in a matter of months, they can have accelerated plaque development and can have obstructive coronary artery disease. Pulmonary hypertension, one of the most common agent that we see pulmonary hypertension is a tyrosine kinase inhibitor, dasatinib. Again, if these patients start developing right heart failure symptoms or shortness of breath, it's very hard to tease out. That's when they need to be seen by cardiologist and evaluated further. Arrhythmias, ventricular atrial arrhythmias, and also heart blocks. I've seen patients come in with complete heart block with immune checkpoint myocarditis, where we have not even put a pacemaker in them after we have treated them with high-dose steroids. Again, they can develop atrial and ventricular arrhythmias and a lot of other things. One of the common chemotherapy is ibrutinib, which is a tyrosine kinase inhibitor that can cause atrial arrhythmias, atrial fibrillation. Again, we either manage them while with the AFib or switch to something that causes less AFib, like acalretinib, because that's an off-target effect of ibrutinib causing arrhythmias in these patients. Or otherwise, we put them on antiarrhythmic medications and watch their QTC, because tyrosine kinase inhibitors can cause QTC prolongation as well. valvular heart disease, commonly in radiation, that we see that both the aortic and the mitral valve are involved. They develop mitral stenosis, aortic stenosis, or vice versa with radiation to the chest. Hypertension, most commonly with tyrosine kinase inhibitors, peripheral vascular disease, and radiation-induced cardiotoxicity, like I mentioned. So you can actually keep going. So TKIs, and I mentioned about this, causing cardiomyocyte damage and also can cause hypertension. Keep going. Immune checkpoint inhibitors causing myocarditis and accelerated atherosclerosis. Proteasome inhibitors causing coronary artery disease. What is that? I can't even read from here. Antimetabolites like paclitaxel, again causing coronary artery disease. Radiation, again accelerated atherosclerosis and also valvular heart disease. They can sometimes cause pericardial disease as well. We have seen calcified pericardium, but again it's very, very rare. A lot of restrictive pericarditis. Microtubule inhibitors like paclitaxel and stuff like can cause some atrial arrhythmias. So does thalidomide, which we don't use. Cyclophosphamide can cause LV dysfunction. And anthracyclines, which I talked about, again, it's one of the most common, and we know from before. And proteasome inhibitors and the anti-HER2, again, these are all reversible cardiotoxicities. The only one that traditionally we thought was irreversible was anthracyclines. And again, I say that with a caveat, it's not irreversible. If we diagnose it early, it can be reversed. We can treat anthracycline patients if we pick them up early, and I'll show you with cases. This is the older definition where we talked about a drop in the ejection fraction of greater than 10 points with the EF dropping less than 53%. That's the definition of cardiotoxicity, and that definition still holds. And another part about subclinical LV dysfunction is if the EF drops, but it is not less than 50%, or if the EF drop is less than 50%, but it is not dropped by 10 points, we can call it subclinical. And also using global longitudinal strain, or GLS, it can be subclinical LV dysfunction if there is a 15% drop in GLS. That's an echo parameter on echocardiogram, where we use the strain, which is an early marker of LV dysfunction. Keep going. This is just images where we use 3D echo and GLS. So newer definitions. Now, I told you about the cardiotoxicities. That's why the newer definitions are updated in 2022. Back 10 years ago, 2014, we were just talking about CTRCD, or cancer therapeutic related cardiac dysfunction. Now we talk about symptomatic, asymptomatic patients, their degree of severity. We talk about myocarditis. We talk about hypertension. Keep going. We talk about peripheral vascular disease, the coronary artery disease, MIs. So these are the newer definitions that came out, and this was a collaborative effort by various societies: European Oncology, European Oncology, Hematology, European Cardiology, and the International Cardio-Oncology Society that came together to put out these guidelines. So besides just imaging, besides echo, which is the workhorse, what else do we use for detecting LV dysfunction? There is biomarkers, which we knew from 2014 as well, and even now, this was a newer paper back in 2020, where we use cardiac-specific biomarkers, a BNP and troponin, to put patients in different categories. If both are normal, obviously there is no cardiotoxicity happening. If a BNP is elevated, then we can think about something that's causing congestion. It could be with tyrosine kinase inhibitors, could be with anthracyclines, or if it's just the troponin that's elevated, then we can think about myocardial injury happening with 5-FU or something like that, or it could be with immune checkpoints. However, if both are elevated, we are thinking something more significant that's happening in these patients. It could be various of cardiotoxicities again, so you can use biomarkers as well for monitoring these patients. Let's look at few cases. So 57-year-old female with history of small cell lung cancer, treated with chemotherapy in the past, now with a newly diagnosed right-sided breast cancer, which was hormone negative and HER2 positive, underwent mastectomy, and was started on with docetaxel and Herceptin. She had a previous echocardiogram at baseline, which showed normal ejection fraction. Subsequently, had a drop in the EF, and Cardio-Oncology was consulted to see her. She was seen in the clinic, had no symptoms, had basically unremarkable exam and ECG. So what do we do about this? So this is a baseline echocardiogram where we have the 4-chamber view. Again, looks like the EF is squeezing well. 2-chamber view was squeezing well. This is on Herceptin. again, that her EF had dropped to 40% range, 45, 40, at a baseline was 55, 60%, had dropped to about 45%. So we got a cardiac MRI, and this is the cardiac MRI. Click one more time. Okay, and that's showing, that's a cine image, again, similar to echocardiogram. We have a 4-chamber view, 2-chamber, 3-chamber, and an LVOT view. It showed that there was no regional wall motion, which means that all the LV was squeezing, but it was mildly reduced. The EF was reported to be 46% on the MRI. Go back. And this is late gadolinium enhancement images, so we can look at other things. As you can recall, this patient had radiation to the chest for the lung cancer. So they can develop radiation-induced myocardial damage. They can have coronary artery disease. So with this, we can rule out there is no coronary artery disease going on because there is no regional wall motion abnormality. There is no scar in the pattern to suggest of myocardial damage, either from radiation or from coronary artery disease. So LGE was absolutely normal. So we concluded this was HER2 cardiotoxicity, and she was started on beta blockers and ACE inhibitors, and in 4 weeks her LVEF improved, and we continued her on therapy. So this kind of emphasizes one of the cardiotoxicities with Herceptin, which we see commonly in breast cancer patients. One of the things is nowadays we are not even holding their patients a chemotherapy for 4 weeks because of a term called permissive cardiotoxicity. There was a trial done in US by Dr. Anna Barak. It's called the Safe Heart trial, where they continued these patients on Herceptin therapy and started them on cardioprotective medications, and these patients had same outcome. So there is a term called permissive cardiotoxicity. We allow the heart to be damaged a little bit because this is not permanent damage. So we allow the heart to have some LV dysfunction. We start them on medications and at the same time continue. Why? Because it's easy for a cardiologist to say the chemotherapy drug is affecting the heart, stop the chemotherapy. But what are we going to do for these patients from the cancer standpoint? You're stopping their life-saving treatment. So with things like Herceptin, we do something called permissive cardiotoxicity. We continue the chemo along with starting medications and subsequently repeat an echo and do other testing. And if their EF continues to improve, we continue the treatment. If it drops, we would stop it. But if it continues to improve or stays stable, we're able to get them through the therapy, because Herceptin, if it's not a malignant or a malignant patient, usually is only used for 1 year. So we are able to kind of continue that in these patients. Keep going. This was on cardioprotective medications. As you can see, the heart squeeze function is much improved. Okay. Next case. A 70-year-old female with history of tracheal stenosis had triple-negative breast cancer, and it's the worst kind to get. And she had mastectomy and was subsequently started on pembrolizumab for the breast cancer. She was referred to us for shortness of breath. Now, it's very tricky, and this is tricky in all cancer patients because they all are fatigued and all are tired. They will be like, I get winded when I walk. And such was her case. She's always short of breath, as in she has some tracheal stenosis. You can hear stridor for her. Now, she had shortness of breath, so she went to her ENT. They admitted her to the hospital, had tracheal dilation, but her symptoms did not improve, so she came to see us in the clinic. And we obtained an echocardiogram and ECG. Go on to the next one. So ECG showed sinus tachycardia. Her troponin was elevated. This is high sensitivity troponin. Was her BNP in the clinic was elevated. We obtained an echocardiogram which showed her EF had dropped. Her baseline EF, because we had seen her for pre-op, she had a normal ejection fraction, had dropped to 43%, and also she had a regional wall motion abnormality in basal anteroseptal wall and the inferolateral wall. Again, now this should raise a suspicion that something is going on. You can keep going. So we obtained a cardiac MRI. This is in a non-cardiac congruent territory, so it's not in the coronary distribution. So we obtained a cardiac MRI. This is a cine lobe. That 4-chamber looks pretty good, but here on the 3-chamber view, let me walk over there. One more time. So there was only this area of the heart that was not speaking very well, and then you can see on this side as well. So it was regional wall motion that she had only in those particular territories, kind of mid-inferolateral wall and mid-anteroseptal wall. Keep going. And we obtained, with the cardiac MRI, and again, this is in a late immune checkpoint inhibitor myocarditis, we were able to pick up the top sequence is the inflammation imaging for people who don't know cardiac MRI. That's the edema So you can see with the arrows where the black arrows are pointing, there is increased signal intensity. Black should be normal, and the yellow and white is where there is water content, which is edema. So in the inferolateral and the anterolateral septum, there was inflammation. And also the bottom is the late gadolinium, which is post-contrast images, where we see there is mid-myocardial enhancement. So this was suggestive of myocarditis in this patient. So keep going. So we diagnosed her with immune checkpoint myocarditis. She was admitted to the hospital. We gave her high-dose steroids for about 3 days, 1 gram of solumedrol. We started her on LV dysfunction medications, kind of beta blockers and ACE inhibitors, and she subsequently improved her EF, normalized, and she did well. However, this is the one instance where I always tell them to stop immunotherapy, because ICI myocarditis has high mortality, up to 40%. So that's why we should never, and that's why it's important to diagnose these people early, because if you delay their treatment even by 48 or 72 hours by giving high-dose steroids, they can have higher mortality. Keep going. So one last case here. It's about a 46-year-old guy who was diagnosed with colon cancer. No significant history except for pericarditis, which was idiopathic back in 2008. And he was started on FOLFOX chemotherapy, presented to the emergency department for left arm and chest pain, which started towards the, all right, so he had left arm and chest pain, which started towards the end of his chemo. And this was his EKG, pretty unremarkable except for his troponin, his EKG just showed sinus tachycardia. His troponin was mildly elevated at 4D1, and rest of his labs were unremarkable. Keep going. So this was his echo when we presented. This is a parasternal long axis view and a 4-chamber view, where you can see the LV is not squeezing well, as you guys might have seen the previous echocardiograms with normal squeezing heart. So LV dysfunction, troponin elevation, and a patient on FOLFOX. We are worried there is something going on with cardiotoxicity. Again, this person does not have a lot of risk factors for other things. So with this, Cardio-Oncology was consulted. We recommended a cardiac MRI to see what was going on. So the LV function, again, on the cardiac MRI, in a few days, it was done 2 or 3 days later, looked okay. EF was 45%, again, mildly depressed. This is 4-chamber, this is 2-chamber, 3-chamber, and a 4-chamber view for his LGE, which is the late gadolinium enhanced images. Post-contrast, this was normal. We also see ECV, which is extracellular volume. We can do a lot of parametric mapping with MRI, and those were all normal. So we suspected this was FOLFOX-induced coronary vasospasm. And this patient was started on beta blockers for the LV and ACE inhibitor for LV dysfunction, and then he was subsequently seen in the clinic. Keep going. So after a few weeks of being on therapy with beta blockers and ACE inhibitors, we saw that his LV function, I don't know why did that not play, but it's okay. So his EF had significantly improved when we held FOLFOX and we gave him beta blockers and ACE inhibitors. But the question again is, what do we do with this patient? As the oncologists in this room will agree that F5FU related chemotherapy is better than other chemotherapies for colon cancer or for GI cancers. And we already saw that he develops coronary vasospasm and has LV dysfunction. So what are we going to do for this patient? Keep going. So what we did is obviously ruled out coronary artery disease as the other cause. We saw his LV function had improved. We put him on calcium channel blockers and nitrates, and this was only while he was getting chemotherapy with 5FU. So 5FU is usually administered as a 2-day, 48 hours chemotherapy. So we gave this patient 5FU. We re-challenged him with chemotherapy with close monitoring, and he continued to do okay. So we alternated between beta blockers, ACE inhibitors, and calcium channel blockers and nitrates while he was getting chemotherapy. And we have successfully re-challenged about a dozen of patients who have developed 5FU cardiotoxicity, even a patient who had developed sustained ventricular arrhythmia, and we didn't even give her an ICD, and we continued her on chemotherapy, and she was admitted. A patient who was worse as the last one with ventricular arrhythmia, she was admitted in the hospital, monitored while she was getting the chemotherapy, and she did okay. what we did for her was give her a life vest, which I don't know is available in India, but it's a wearable cardiac defibrillator, but that was never used. So I think for the next patient we are not even going to do a life vest. So again, it's not there is not a literature about re-challenging patients with chemotherapy, but we have been successfully be able to do that. University of Pennsylvania and others have submitted a couple things about 5FU re-challenge, but it can be done. That's why it's most important for cardiologists and oncologists to work together to is to make sure these patients are okay to begin with, and B is when they develop cardiotoxicity, how to manage them so that we can continue to give them their life-saving chemotherapy. Otherwise, these patients will have higher mortality from the cancer standpoint. No? Nice. I think you went backwards. Keep going. Yeah. That's his EF, which had improved. Keep going. All right. So looking at diagnosis and management. Again, this is the important paper that I keep referring to, the 2022, when they put out the guidelines, again, combined with all the societies I mentioned again. And also before that, a paper came out about talking about baseline risk stratification, which is the most important thing that we can do for these patients. So baseline risk stratification is basically looking at the risk factors and putting these patients into buckets, whether they are the light blue bucket is the low risk patients and their risk of cardiotoxicity is very low, and the dark blue at the very right bottom is the patients who are high risk, which they have high risk factors, all the other risk factors, pre-existing coronary artery disease, pre-existing heart failure, all the other risk factors, and along with that, they're going to get highly toxic cardiotoxic chemotherapy. So we kind of divide these patients in the bucket, and based on that, we decide what to do, and this is the recommendations. Besides on that, what is recommended that should be done for these patients before getting specific chemotherapies. Like for anthracyclines, high-risk patients should get biomarkers and echoes. Similarly for all the other groups where they talk about high and low-risk patients. And as you can see, even low-risk patients, they don't need other things if they don't have anything. It's class 2 recommendations, which is not necessarily needed. So all these therapies need to be kind of tailored. Again, this is guidelines, and I was just talking earlier here that these are guidelines. We can obviously adapt them to what's going to best fit our patient population, because again, we can't keep getting echoes in every single patient who is going to get chemotherapy repeatedly, or say a malignant breast cancer patient who's going to get Herceptin or trastuzumab for more than a year, because getting echoes every 3 months, A, it's expensive, B, we are torturing the patient. If the patients have been stable, we don't need to keep pushing these patients. So I alternate between biomarkers, BNP, and echo as well. So again, guidelines are guidelines. We take it with a grain of salt and see what best works for the patients. Keep going. So role of imaging. Cardiac imaging plays a major role in managing these patients, as you saw from all the 3 cases of different cardiotoxicities. Echo is the workhorse. It's cheap, it's readily available, and it should be used for all patients for baseline screening. If something's wrong, we go to the next step. We either get a cardiac CT or cardiac MRI in diagnosing these patients. But it's important so that we can assess these patients at baseline. It's important for surveillance and also for diagnosing accurately the cardiotoxicities that we saw. Similarly, this is a care pathway, again from the 2022 European guidelines, where they talk about what to do with these patients while they are getting cancer, and also the long-term follow-up. Again, class 2 recommendations for echo after every 1, 3, and 5 years. But again, for high-risk patients, if they are low-risk patients, we don't need to keep doing an echo after they have completed cancer therapy. So some things that we have to develop based on the guidelines and what works for the population. Okay. So how do we treat these patients? As you saw from those 3 examples, there is nothing fancy, no fancy cardiac medications. We use the regular MRAs, the beta blockers, the ACE inhibitors, and ARBs. But how do we use, again, the treatment of cardio-oncology is a spectrum. We start treating them before they get started on oncological treatment. High-risk patients, they should be seen by a cardio-oncologist before they get started. If they have known heart failure, if they have known coronary artery disease, have other risk factors, smoking, hypertension, hyperlipidemia, they have multiple risk factors. If they are one of the dark blue bucket patient, and before you start them on, say, any cardiotoxic chemotherapy like anthracyclines or something like that, you should be evaluated by a cardiologist or cardio-oncologist so that we can optimize their medications, make sure they're on the right medications. So, some things that I do is, if they are on, if they have hypertension, they are on amlodipine and hydrochlorothiazide, I would just switch them over to beta blockers and ACE inhibitors. That's going to be cardioprotective, and they can continue those medications, you know, because amlodipine is easy to start, and hydrochlorothiazide, obviously standard line treatments for hypertension, but they don't need to be on beta blockers for hypertension treatment. But if they're going to be on potentially cardiotoxic therapy, we can switch treatment around. So primary prevention before they get started on treatment. Secondary would be when we develop subclinical LV dysfunction. That was the first patient I showed you, where with trastuzumab she had LV dysfunction, but she did not have symptoms. And treatment is obviously when they develop symptoms, the myocarditis patient I showed you, or the FOLFOX patient I showed you, and there would be specific treatments for that. So primary prevention, I already told you, it's just basic stuff, as in knowing, awareness, aspirin, blood pressure control, cholesterol, stopping smoking, diet, and exercise. This is from the European guidelines again. That was 2022. Same thing about the light blue is patients developing cancer for the first time, and the purple is second time cancer when they're going to have chemotherapy again. So baseline risk, cardiovascular risk assessment, and also in terms of treatment, standard stuff. Minimize the use of cardiotoxic drugs, but sometimes you have to use them. ACE inhibitors, beta blockers. One of the important things I want to point out to dexrazoxane. How many people in the audience have heard about dexrazoxane? 1, 2. Okay, dexrazoxane, none of the cardiologists would have heard about it, and nobody knows what it is. Oncologists have heard about it, but I don't think so a lot of people. Have you guys used it? No. So people who have heard it have not used it. And people, so it is a medication that we use for preventing. The way I teach my our fellows and trainees when I give talks is, dexrazoxane is a medication that we can use. It's an antidote for anthracyclines. It reduces the cardiovascular side effects of anthracyclines. So should we use it for everyone? Not necessarily. It's only for patients who are going to get higher dose anthracyclines. So if I see a sarcoma patient who's going to get a dose of about 400, 450 milligram per meter square of anthracyclines, then I would start it at 300. Patients who have had breast cancer treated on one side and now they develop contralateral breast cancer, and they got anthracyclines for like 4 rounds, where it's like 60 or 75 times 4, they have already gotten up to 200 or 250, then I tell them to use dexrazoxane along with doxorubicin to prevent cardiotoxicity. If a patient has known heart failure, the LV function is like in mid-40s or mid-50s range, or maybe low 50s, say, and they're going to get anthracyclines for lymphoma or something like that, then I would say you don't need to avoid anthracyclines. You can start them on beta blockers, ACE inhibitors, along with that give them some dexrazoxane and treat them with anthracycline so that they can get the best treatment for their cancer, and at the same time we protect their heart. One of the important things I want to point out is statins. As in, statins have cardioprotective effect, and that has been seen in a lot of retrospective studies. However, there was a land-breaking trial. There was a trial that came out a couple years ago by Tom Nealon and his group from Boston, where they gave statins, moderate intensity statins like Lipitor 40 milligram, to patients who are getting chemotherapy with anthracyclines at a dose of close to about 300. Anywhere patients between 250 to 300 milligram per meter square of anthracyclines got statins. Half of them got statins, half of them did not. Patients who got statins, moderate intensity, did not have a drop in the EF, versus the patients who did not get statins had a drop in the ejection fraction. So statins are cardioprotective. So I put these patients on ACE inhibitors, beta blockers, statins. High-risk patients who are going to get anthracyclines get on dexrazoxane. So that's simple. Again, liposomal anthracycline preparation is better as compared to the traditional one. However, it's expensive, so a lot of people don't use it. And again, if we can use liposomal, they have less cardiotoxicity. That's again a thing. But again, we have to always kind of weigh in terms of cost versus benefit, and if that's going to be possible. One slide explaining why we start treatment early, and this is anthracycline patients. So you see, we started cancer treatment with the yellow arrow, and this is the patient where they start developing subclinical LV dysfunction, is when their EF starts dropping. But this is when they start developing symptoms. But if we know that their EF is dropping by doing echocardiograms while they get chemotherapy, then we can treat them and they will improve back to their baseline. Or if we treat them like in 6 months, this is 6 months mark, they will improve but not come to here. And this is when they develop heart failure symptoms, where they will not improve, only will keep getting worse. So it's very, very important that we recognize these patients so that we can treat even anthracycline patients, cardiotoxicity patients, and improve their ejection fraction versus them progressing to heart failure, which is kind of the type 1, irreversible kind that we knew about. Specific management, I already talked about all of these. Interrupting or switching to non-cardiotoxic chemotherapy and the standard treatments for that, dexamethasone, the calcium channel blockers and nitrates, and we talked about myocarditis as well. We can go on to the next one. So, take-home points. Cardio-oncology is a collaboration where we want to treat the patients so that their hearts are protected, and our aim is not to interrupt or stop the therapy. We want, the importance I want to highlight is surveillance. We need to monitor these patients so that they don't develop cardiotoxicity, like with anthracyclines and HER2. Talk about imaging and biomarkers. Again, it's the cross-disciplinary and the multimodality approach where we make sure these patients' hearts are protected while we get cancer treatment. So future directions, as we were discussing, kind of build a team, train the experts, get the essential equipments, and establish protocols which can be applicable to here, our cancer center. And our cardio-oncology department is actually in the cancer center. We started that. And that's my team. We have myself, the medical director. We have our oncologist who works with us. We have a nurse practitioner who works with us. Again, it's not a consultant and a pharmacist. Again, things can be tailored to how we can develop programs at places like Cherian. This is kind of the timeline. Keep going. So where we started, where I first started the program, and we went on to buy an echo machine for the cardio-oncology specific population, where we expanded and keep going. And that's kind of how we are ready to hire another cardio-oncologist at a program. And that's our growth in terms of how many patients we were seeing per month. We're 2 to 3 into now 140, 150 patients per month. So, and this is kind of the various diagnoses. We see everything from anthracyclines, pre-chemo, pre-CAR T therapy, coronary artery disease management. We see hypertension. We see immune checkpoint myocarditis, arrhythmias, HER2, tyrosine kinase inhibitors, pericardial disease, valvular heart disease, so all kind of things. So again, it's a growing process. It's a newer field. Even when I went to University of Kentucky, we did not have anyone. And in the 3.5 years, as you saw, how the exponential the growth has been. So it's a growing field. There is a lot of need, and it's I guess, and I'm pretty sure the need's going to be everywhere in India as well. Keep going. And I want to thank my team and my family for letting me go away from the vacation. That's my family down there, my kids and my wife. And I want to thank my mentors. And I, again, want to thank the organizing committee for having me here to discuss this most important topic about cardio-oncology. And before I take questions, there was one thing that Dr. Sarah had mentioned about malignant pericardial effusion is what the cardiologist wanted to know. There is not a lot of data about how to manage malignant pericardial effusions. However, I'll tell you our experience in terms of what we do. These patients, usually we see them, either they have lymphomas or something, they come in with malignant pericardial effusion, but not a lot of them require tapping multiple times. After we have tapped their effusion, and obviously we do a diagnostic tap or in terms of therapeutic, but after that, once they're on standard chemotherapy for whatever their cancer, either breast cancer or lymphomas, they don't get recurrence a lot of times. If they get recurrence, we do one of the two things, either window, which is a standard treatment, but if the patients are high risk and are not great candidates to even go and get a surgical window, we put a Pleurex catheter in their pericardium, similar to what we put a Pleurex in their lungs. So we put a Pleurex catheter and drain that and keep that on for weeks at a time. And after that, we have not done anything beyond that, and we have not needed. So that Pleurex comes out after a few weeks, and these patients usually do okay. Sometimes if I see non-malignant effusion, again, which is again common in cancer patients, and there is a lot of inflammatory cells, I put them on colchicine for 3 months, and they do usually tolerate it okay. So that's what I've done for managing pericardial effusions in these cancer patients. So I'll go on to the next one. And Point, point 0.6 milligram. Yeah. The standard pericarditis dose. 3 months. Yeah. And there is only one patient I've used rilonacept, which is an interleukin inhibitor. But out of the 1,000 patients, I've not had maybe less than 5% of pericardial effusion that we have to manage, but mostly colchicine, the one I've used the most. And again, like I said, window in few patients are Pleurex catheters.
Thank you very much, Dr. Arbune. So now it's time for a question and answer session. You can raise your hands, you can come to the front. If anybody has any questions for Dr. Arbune.
Especially in younger patients, do you have patients who go on to require more advanced treatment for LV dysfunction in form of mechanical support and ongoing, either it's a bridge to recovery or a destination therapy?
Yeah, good question, actually. Keep going. I have a slide on that. I didn't want to bore you guys with a lot of slides. I have, yeah, this is kind of the anthracycline data. Keep going. More. Stop. So there is data about that. So patients who got LVAD, and we did a 10-year through Intermax study. Patients who had LVADs for anthracycline induced cardiomyopathy had similar outcomes to non-cancer patients. And also for heart transplant data, again, there is limited data, but looking at kind of 20 years worth of data, 10 years worth of data, 257 patients with anthracycline cardiotoxicity did get heart transplant. So heart transplant is also an option for these patients. But again, they have to be kind of cancer-free for 5 years, and they have, so mechanical support is something that we use. This is long-term. Something about short-term for immune checkpoint myocarditis. We see a lot of these patients. In the past, we were seeing more, but now we see them early. But we were seeing a lot of patients coming in with fulminant myocarditis. So we put them on ECMO. We put them on mechanical support and treat them with high-intensity steroids, or even higher big gun things like IVIG, antithymocyte globulin. We have treated them with abatacept, and they have recovered and they get off support. So those are the two instances. Anthracycline, because this is long-term cardiotoxicity, and in the short term, when they come with fulminant disease like myocarditis, we've used MCS.
ACM is mostly remote exposure to anthracycline.
Yeah. If it's a childhood person who've had anthracyclines, and later on in their life they developed anthracycline cardiotoxicity. I had recently had a 21-year-old who I diagnosed with anthracycline cardiotoxicity. He got chemotherapy when he was 10 years old for sarcoma in his thigh that was excised, and he was doing okay until like a couple years ago. He was not having symptoms, but echo showed RV was having dysfunction early on, and now we've started him on standard therapy. But if someone like that who's been cancer-free continues to progress to develop heart failure, or is not diagnosed early on, that we don't treat him early, and he develops heart failure in his 30s, so that person could be someone who can get LVAD or subsequently transplant, or either or. Any other questions?
Basically, from the surgical point of view, a patient has taken colorectal cancer, they have taken a 5FU and had a cardiac toxicity. So how long we have to wait for taking up for surgery that patient? We routinely, after 3 to 4 weeks of completion of chemotherapy, we used to take up for surgery.
Yeah.
But if a cardiac problem has happened in between,
Yeah.
whether we have to wait little more, and also any other precaution we have to take, like in the medication, just like you told, like while giving a 5FU, you are giving nitrates also in between. So during the perioperative period, we have to supplement any other cardioprotective agents.
Sure. Yeah, great question. So if they have developed cardiotoxicity, and like I showed, this guy's EF improved. So if you have treated them while chemotherapy with calcium channel blockers or beta blockers and ACE inhibitors, and the EF has improved, I would not do anything differently, because this guy underwent surgery, he did okay. There is no need for calcium channel blockers and nitrates. That I've only used while they're getting that 5-FU chemotherapy. After that, I've even stopped calcium channel blockers and nitrates in these patients. So we have about 12 patients, and they did okay. There is nothing specific they need prior to surgery. If their LV function is still not improved, or if it's brand new that we see 5-FU chemo has caused LV dysfunction and their heart function is down to 20-30%, I would wait for the LV to recover in, like, say, at least 4 weeks or so. And if the LV is recovered, then I would take them for surgery if we are not going to give them further chemo or if they've completed chemotherapy. But usually if they develop 5-FU cardiotoxicity, it happens with the first cycle. So if the patient have tolerated first couple cycles, I have not seen any 5-FU toxicity that happens later on. So usually you would want to give them more chemo to shrink their tumor so that they're resectable. And so they don't need calcium channel blockers and nitrates after they've completed chemo.
2-3 doubts also.
Sure.
Sir, it's the same thing what we see after stress cardiomyopathy we are seeing after surgery.
Right.
Is it a similar picture what you are seeing in cardiotoxicity?
That's a very good question. There is a study that's ongoing right now, just started a few months ago. So it's like with stress cardiomyopathy, a stress will cause LV dysfunction. We put them on medications. Similarly, chemotherapy is a stress, so like Herceptin or is 5-FU. And what do we do for these patients after they've completed chemotherapy? Do we stop the medications? Do we continue? From what I am doing and from what various centers are doing, if they have other risk factors, if their blood pressure is still high, would continue them on medications. But if not, then there is a good chance that they will not have that again because we are not going to give them chemo again. So we can stop. But there is a prospective randomized control trial that's on the way that is looking at the very same question, whether to continue these drugs or to stop them. And if you stop them, what happens to these patients? So it's going to be a 5-year-long study, and we're going to find out more about from a randomized control trial standpoint.
And also one more point, like you told, like we have to find patients before the subclinical symptoms have started.
Yeah, before the symptoms. Subclinical is before they've developed any symptoms. So the ideal patient would be, obviously, besides baseline, if they develop something, is if they have LV dysfunction, we pick them up early so that we can treat them and they don't go on to develop more overt cardiotoxicity.
So as a screening marker, whether we can use this TROP-I or ProBNP
Yes.
routinely, is there any data regarding like that?
Yes, there is data about BNP, about using for screening. And for troponins, they looked at actually for myocarditis. There is no data about continuing to check troponin all the time. But for myocarditis, if they develop symptoms and troponin is high, that's useful. But for LV dysfunction, for Herceptin, there is data about BNP, which can be used as baseline. And if it's elevated, then we kind of suspect about LV dysfunction. And same thing with anthracyclines. There is data about anthracycline causing BNP elevation. So it can be used, definitely.
Because after surgery, because there is an entity from surgical side, myocardial injury in non-cardiac surgery means. So what we do is like in after surgery, 3 to 5 days, if the TROP-I got elevated, these are the patients we select, like these are the, we triage the patient, and these are the patients for high risk for developing this cardiomyopathy after surgery that we have seen. There is data coming from the surgical side. That's why I asked whether TROP-I based studies are there.
Yeah, there is a lot of BNP based studies because we are looking at LV dysfunction. The troponin studies were a lot done for myocardial injury type. Again, I'm sure there might be studies that look at troponin only, but I just know about BNP, primarily studies for LV dysfunction with anthracyclines and Herceptin based.
And one more question, is there any role for antioxidants? Because most of the time it will be a free radical injury.
Right.
So is there any, while on chemotherapy, whether we have to give antioxidants like L-carnitine and acetylcysteine, glutathione or anything which can decrease? Is there any?
So very good question. Again, we don't have much data about that because there have been no studies done for that. As I showed you from the beginning slide that they have shared risk factors. That's one of the risk factors. So I'm pretty sure that it probably works, but we just have not seen anything in terms of patients or long-term data or bigger studies if oxidative stress, if using those are going to improve the LV or prevent cardiotoxicity, but we don't have studies looking at that. Right now, focus has been in terms of how to prevent it, how to treat it with the standard medications, but I think that would be the next step to look into what to do next beyond these. Thank you. Great questions.
endomyocardial biopsies.
Yes.
So just for the rest of the house, how often do you rely on endomyocardial biopsies to
Sure.
guide your treatment?
Yeah, great question. Again, immune checkpoint myocarditis, I showed you a case where we saw myocarditis on the cardiac MRI, but I use a lot of endomyocardial biopsies. Two things is the data on the on MRI, and this is a paper that is coming out soon that we are using multimodality imaging. As you saw for myocarditis, immune checkpoint, we use multimodality imaging. We saw the echo was abnormal, what's the role of CT and MR. But MRI data has, in the past was very good for myocarditis, immune checkpoint myocarditis. That's when we were diagnosing these patients late. Now, however, since we are being more aware that we are suspecting immune checkpoint myocarditis, we are picking up patients early on where they have slight elevation of troponin or some symptoms, and they are being referred to cardio-oncology. And I've seen patients who have MRI, which is non-diagnostic or inconclusive because they're early on, and they have not developed so much of inflammation or fibrosis that can be picked up by T2 mapping or LGE. And in those patients, we have seen the endomyocardial biopsy being positive. And again, sometimes there is a time constraint or resources availability for getting an MRI. So my immune checkpoint myocarditis patients, I'm relying more on endomyocardial biopsy. So we first go to biopsy. What I do is, and this is what I train my fellows and teach them, is when you suspect immune checkpoint myocarditis, is you send them for a biopsy, you start them on steroids right after the biopsy, because if you delay steroids by 48 or 72 hours, these patients have poor outcomes. Even like MACE is lower, a higher MACE if we delay the steroids. There was a study, and I think I might have some slides. Keep going. Keep going. Yeah. Let me see, because there is a very good study that was done again by Tom Nealon and his group, and he's one of the pioneers in immune checkpoint myocarditis. See it next. Keep going. Next. More. So again, I have more cases. There is anthracycline. Keep going. This was an anthracycline case. Never mind, I don't know. It should be there, but there are about 100 slides in this deck. I think, radiation cardiotox, no. Okay, so not in this deck, but there is data about immune checkpoint myocarditis. That's why diagnosing is early. Again, we talked about MRI availability. It's not the sole thing that we need to rely on. Endomyocardial biopsy, if it's readily available, then I would do that. One caveat is sampling error has been a traditional problem with endomyocardial biopsy. So what is recommended is take good 6 samples, because I think for heart transplants, they usually take 3 samples for endomyocardial biopsy. Nice 6 samples, echo guided, if we make sure you get different areas of the septums. So we use echocardiogram, transthoracic echo, while getting the biopsy, kind of poking on the septum, seeing where we are getting it from there. So echo guided 6 samples is kind of what has been told by people, experts who have been doing this. And we, most of the patients have had positive endomyocardial biopsies. If the biopsy is negative, I'll stop steroids and let the patient be, and it's not the cause for concern.
With this anthracycline chemotherapy, it's often the effects are even remote, isn't it?
Absolutely.
So what is your protocol of following somebody who has had anthracycline chemography as in a younger age?
Yeah, so goes back to the first question, baseline risk stratification. If they are low risk, you can get them echocardiograms every 5 years or so, if they have had significant anthracycline dose. If someone who had, like, say 225 for breast cancer, a young female in their 30s got breast cancer and got lower dose, then again, you can stop them after 5 years or so. But somebody who had like high dose, 450, like a sarcoma patient that I described, had anthracyclines, then we do 1, 2, 3, and after that every 5 years. But in initial years, if they start having, and if they have higher risk factors, if they have other things like smoking or high blood pressure or high cholesterol, we would do them more frequently. Again, it has to be tailored by patient to patient. We can do them every couple of years to make sure that we don't miss this.
And how long would you keep doing it?
So for high-risk patients, probably it's going to be lifelong. And for low-risk patients, again, we can stop at 5 to 10 years. Again, some of the thing is evolving data, which everyone's kind of playing by the ear and see how it goes. but as we saw these long-term follow of these patients, so they end up seeing us lifelong after they've had a significant anthracycline or they've had radiation to the chest, so that we make sure that they're not developing symptoms. At any point we think that their exam is changed or they are developing symptoms, then we would get more imaging done. But at least they should have a clinical exam or being followed by a cardiologist or a cardio-oncologist on a long-term basis.
Thank you for that informative presentation. We were discussing on cardiac complication developing in a non-cancer patient. I have a different question.
Sure.
A newly developed malignancy in a non-cardiac patients. Recently, we had a patient who was had a recent MI. He was being evaluated for doing a CABG. On a chest X-ray, found to have a lung mass, and a CT scan found to have it's a carcinoma lung. So in these patients, what is your advice? How long we have to wait? Or is there any tests that have to done before starting the chemotherapy and other process?
Great question. Again, we see something similar to that as well. A lot of times the cardiologist or surgeons would be apprehensive for a patient who's going to have surgery or has developed cancer to take them. Again, there is a dilemma about patients getting transplants, like I said as well, that we diagnose indolent cancer where we were not even looking for that and are being evaluated for surgery. So there are no specific guidelines about how long do we wait. In cancer patients, if they need cancer surgery and they've had recent stents, with the newer stents we can take them even after just 1 month of dual antiplatelet and take them for surgery. For post bypass, again, depending if they've had an uncomplicated course, they can relatively go sooner for cancer surgery. They don't have to wait for like months. They can go after a month or so. Again, if they've had everything has been gone okay. Again, like I said, with newer stents, I don't even wait for more than 1 month, 4 weeks of dual antiplatelet, then stop the antiplatelet or just put them on a aspirin or Plavix and go for cancer surgery.
For chemotherapy?
Even for chemotherapy, chemotherapy it can be in 4 weeks. We can easily start as long as they've not had any problems. Yeah. And sometimes we have even continued. If they're while chemotherapy they develop an MI, and if they do okay, we would start it right away in few weeks. Yeah. There's no guidelines. Again, it's everyone's doing what's the best and how the patients are doing.
Anybody else? Thank you very much, Dr. Arbune. Next is going to be vote of thanks by Dr. Devarajan. But before we do that, KMC want to express our gratitude, and we have a token of appreciation. Dr. Madhu Paulus will give a gift to Dr. Arbune. And I request all the cardiology team and the oncology team to come to the stage so we can take a picture. Dr. John, Dr. Bose, Dr. Murali, Dr. Anand, Dr. Devarajan, Dr. Arun. Dr. Givers, please. Yeah. I think you have to stand in the middle. I think. So I think we can just come this way and we can stay in the middle, right? Everybody's here, right? I'm not missing anybody? Okay. No, we have to give, yeah. Okay, take a picture. Mic? Dr. Devarajan, our consultant cardiologist, will give a vote of thanks.
Good evening to our honorable chief guest and speaker for today's meeting, Dr. Amit Arbune, Assistant Professor of Medicine, Cardiologist, Director, Cardio-Oncology Program, University Kentucky, USA. And Dr. Givargis K. Matthew, our Medical Superintendent, Dr. Anand Srinivasan, Consultant Cardiologist, Dr. Sarah Isho, Medical Director, Oncology Department, dear colleagues and friends. It is my privilege to propose a vote of thanks. On behalf of Dr. K.M. Cherian Institute of Medical Sciences and all those who have assembled here, I extend a hearty vote of thanks to our chief guest, Dr. Amit Arbune. He has spared his valuable time from his busy schedule to grace this occasion. Today, your speech has enlightened our minds, and we had the opportunity to learn a lot of information regarding cardio-oncology. Thank you, sir, for arriving here to deliver this lecture. I also thank Dr. Anand Srinivasan for his presentation regarding the cardiology department. My sincere thanks to Dr. Sarah Isho, Consultant Oncologist, Director of Oncology Department, Dr. K.M. Cherian Institute of Medical Sciences. She is actually the brain and the activity and the driving force behind this program. I am sure that she will definitely develop this novel specialty in our institution. And no doubt, the cardio-oncology section will be helpful to many oncologists and patients to successfully complete their treatment programs. Last but not the least, I thank each and every one of you for attending this meeting and made it a success. Once again, thank you all.
So the meeting is officially done. If anybody has any questions to Dr. Arbune, you can ask him of the now, and it's time for dinner. Once again, thank you all of you.